está el simposio, las mariposas están libres, interacciones entre mente y cuerpo, en lupus y enfermedades reumáticas autoinmunes. La música
es parte de la terapia.
Las mariposas se están volando.
Ahora no, músicos de la... Ahora sí.
Ok, nuestro primer ponente es el profesor Samlin. El doctor Alberto Palacios nos va a hacer el favor de presentar.
Me da mucho gusto estar aquí. Este simposio fue idea de la doctora Cristina Drenthal, que trabaja con el doctor Samlin en Atlanta, y quiero reconocerla aquí porque ella es la que ha tenido todo el entusiasmo de combinar estos dos campos tan interesantes. Lo que van a oír ahora del doctor Lim es una parte del trabajo que ellos vienen haciendo desde hace 15 años con una cohorte de pacientes con lupus en Emory y en la zona circunvecina Atlanta. Realmente es un trabajo extraordinario. Yo creo que los pocos que estamos aquí lo vamos a gozar mucho y vamos a entender además la importancia que tiene el hacer estos grupos multidisciplinarios para luchar contra las inequidades y las diferencias de tratamiento que vemos en nuestros países. Quiero presentar a mi buen amigo el doctor Samlin. Él es profesor de medicina en la división de reumatología en la Universidad de Emory, como ya dije, y además profesor de epidemiología en la escuela Rawlings de salud pública en Emory. Es jefe de reumatología en los sistemas del hospital más importante de Atlanta, que es el Brady Health System, y además es un entusiasta del lupus desde muchos ángulos. Ha trabajado sobre todo con aspectos de diferencias raciales, diferencias de clase, diferencias de nivel socioeconómico. Es muy activo tanto nacional como internacionalmente en este campo, y su grupo representa en la actualidad 43 centros de estudio en disparidades en lupus. Eso es impresionante en la Unión Americana, y están elevando, según me comentaba, la idea de crear un comité especial que ha sido creado para el tratamiento de disparidades, particularmente en lupus y en otras enfermedades autoinmunes. Es un gran honor tenerlo con nosotros.
The organizers of the meeting, it's been very impressive, not surprisingly so, to see the turnout and the quality of the presentations and the abstracts. I also apologize that my Spanish is not very good, but if it makes you feel any better, my parents are always disappointed that I forgot my Korean too, so anyway, we'll move forward. So I want to start my story by talking about some history of the US. Back in 1910, I don't know if you knew that more than 90% of the African American population in the US was living in the southern United States, among these states down here. And then by 1970, there was only about half. And what happened over that period of time was this so-called Great Migration. It's the largest social internal migration in the history of the United States, where African Americans moved in very large numbers from the South, primarily moving away from discriminatory laws and regulations, and also seeking economic opportunity in the industrial North. But what's happened in the past couple of decades is what is now called the Great Reverse Migration. And with opening up of laws and regulations and throughout the country, including the South, and further economic opportunities, a lot of the African Americans moved back. And here in this map, the cities and the areas that received a lot of the African Americans during this time are in the darker colors. And the cities that have lost more African Americans than received them are in the lighter colors. And the larger the circle is, the larger the number of people there are, either lost or received. And during this period of time, Atlanta was the largest recipient of African Americans of any city in the United States. And that's one of the backgrounds behind why we were lucky to be chosen as one of the first CDC-funded lupus registries, along with the University of Michigan. The primary aim of this registry is to have a more updated and accurate incidence and prevalence of SLE estimate. Since then, actually, Michigan and Emory were picked because we're in areas of large African American penetration. But after us, the NYU in New York and the American Indian Service and UCSF in San Francisco were also chosen because of the different socio-demographics in those areas. So our job was to find as many people with SLE that we can adjudicate or validate within a very discrete population area in a certain period of time. And we chose, in terms of time, 2002, 3, and 4, to identify incident and prevalent cases. These are all cases, severe, mild, those seen in our institution at Emory, but as well as those seen in the private practices throughout of all socioeconomic class. And given our methods, which I'll mention very briefly in a minute, it's impossible to do it in a huge area. We would have loved to have done it throughout the entire Georgia, which is at the bottom left here. And you can see all these lines represent local governments or counties. And the areas that are highlighted here is the metropolitan Atlanta area, which is a very large area. It encompasses almost 6 million people, very diverse. And if you do come to the ACR meeting this year, I hope you appreciate some of that diversity. But we chose, for a variety of reasons, these two counties right in the middle, Fulton and DeKalb, in large part because it had such a high concentration of African Americans. It's essentially half black, half white, 1.5 million people, half male, half female. The poverty rate is about 13% at that time, with about a third with advanced degrees. And the poverty and the low socioeconomic status and educational attainment were not all in the African American population. There were wealthy African American neighborhoods as well in this area. So it was a very nice gradient across all groups to detect differences. And just very briefly, what made us a success is that we partnered with our state health department that viewed us as a public health project. So therefore we were able to go into facilities without patient consent, obtain information, identifiers, private information, keep them, and utilize them to validate cases. So we approached almost all the hospitals, rheumatologists, dermatologists, nephrologists within those two counties as well as around those counties. And when we went into a facility, we abstracted or obtained information from a variety of places. We went into their electronic medical record system or whatever billing system they had. We looked for everyone who was coded or billed as lupus or related to lupus. We also had access to population laboratories, so people with high titer ANAs, low complements, double-stranded DNAs. They were identified and where they were. We got pathology results from kidney biopsies and skin biopsies throughout the population, as well as other population databases. So when we walked in with our army of abstractors, we had a pretty decent idea of who may have lupus. And then we screened all of these different lists to find people that lived in those counties within those years, and then we ultimately abstracted thousands of medical records with these trained abstractors looking for as much information as possible, and then we essentially obtained our cases. Now this was a tremendous effort. It took about 7-8 years. At the end of the day, we had an amazing resource in this registry of people who actually had no idea we were looking at the records. We identified them as probably having lupus. They met the classification criteria. We knew who they were, where they were, how to contact them. And we thought that with all that effort that we put into here, we would love to be able to follow them over time, ask them questions that were not available in the medical record, and learn more from them. And then we called this effort the Georgians Organized Against Lupus, or GOLD Research Cohort. And we've been doing this over the past 6 years. And this population-based cohort is currently over 1,000 people with validated SLE. The vast majority are from the original registry. We got 3/4 of them, contacted them, they agreed, they consented. We supplemented, obviously, from the clinics that we have in our university system, rheumatology and lupus clinics, but that's a biased group, and so we reached out to community practices in very diverse areas, looking for more incident type of cases to kind of replenish the cases that we lost, unfortunately, to death or lost to follow-up. And we've maintained a very large diversity of disease severity and socioeconomic spectrum that represented the original registry that is now in the current cohort that we're following prospectively. And we've asked these patients who have been very kind to at least commit to annual data collection from surveys. They also opted to be apprised of new opportunities of collecting biospecimens, and they also gave us permission to match with other population databases. Now, the next few slides are not meant to overwhelm you, but just really give you a sense of the type of data that we've been collecting. So in terms of disease severity, you see that, again, only half of this very large group are people that we see in our institution. The rest don't even know who I am or who Emery is. They are seeing their private physicians, they're happy with them, so we do not have face-to-face daily contact with them. So in order to get disease activity or organ damage, we use patient-reported validated instruments like the SLAC, and then the build is a validated patient-reported damage measure. And then you see that we also collect components regarding mental health, and again, these are descriptions of the measures in the second column, and the specific validated instruments I've listed to the right. But just get a sense of the scope that we're doing: mental health, physical health, social health, their work and employment status, which is very important in the US because that's really the basis of access to medical care, which is health insurance through your employer, medications, aspects of self-management. Then we have neighborhood and geographic factors. We have their addresses, so we can geocode them, get their latitude, longitude, match that with other population databases, that from the census, US Census and other databases. We ask the patients themselves about what their status of their neighborhood is. Social stressors and barriers regarding discrimination, stigma, their neighborhood domains, financial strain, childhood trauma, perceived stress. Surprisingly, or maybe not surprisingly, a large proportion of people have direct experience with being incarcerated or in prison, and emotional and social support. Treatment adherence, access, health-related behaviors, social isolation, religion, resilience, and I'll touch a little bit in a little bit about cardiovascular disease. And I mentioned that we also have permission to reach out to them for other related studies, and we had an amazing opportunity to gain biospecimens from the vast majority of our patients who were willing to come in, give blood, and we work with Dr. Ignacio Sanz, who's our division director, and he's looking into B-cell phenotypes and specific autoantibodies. We have people looking at various inflammatory endothelial markers, and we have banked serum, plasma, DNA, and RNA for future studies. And then I mentioned briefly that we can match these people with other population databases that allow us to see over time who's gone into end-stage renal disease and are receiving dialysis, who's had cancer, birth outcomes, matching with birth records. We have over 450 births from these people with lupus that we're currently analyzing, who's died, who's utilized care within the state of Georgia. Everybody who's been to an emergency room or hospital in the state of Georgia is reported to a registry. We match them with our registry and we learn about their utilization and outcomes in that regard. And then I'll briefly mention within these two counties, the other advantages is not only is Emory University here, but just 1 or 2 kilometers away from where the ACR meeting will be held is a great hospital called Grady. It's owned by these two counties. The main charge of this hospital is to take care of those without insurance in these two counties. They get partially their revenue from taxes from the residents of these two counties to care for these individuals. And this is where I spend most of my time. We have a lupus clinic there. So for people who have a challenge socioeconomically, staying in a research cohort, may not have adequate housing, they have difficulty adhering to research protocols, they eventually come see me, unfortunately, because they have nowhere else to go. And we take advantage of that opportunity to make sure that their voices are heard by completing a lot of our research records when they come and see us, so that they're not underrepresented. This is a group that I think we lose a lot in population-based studies, especially in the US. So let's just give you an idea of who these people are. They're diagnosed around age 30. They're about 44 at the time they took their first survey, 92% female. And as I mentioned, the vast majority are African American, 81%, 16% white. and a smattering of others. Hispanics in our area was about 4.8% or 52 individuals, but a very robust Latin American group outside of those 2 counties. They just were not represented in the cohort that we have. The educational attainment, as I mentioned, it's fairly decent. It's 12 years is finishing high school, so the vast majority of people have some form of college and advanced degree. But despite that, you see that they're living in poverty in the US. 43% are at or below the federal poverty level. So the average salary, annual salary for someone in Atlanta, for one individual, is about $50,000 a year. And the federal poverty limit is about $12,000 for an individual, barely enough in a wealthy country like the US to live. And in this cohort of population-based lupus, we're saying that almost half, 43%, are at or below poverty, and only 28% are working full-time, and therefore have very difficult challenges getting insurance. Now imagine what that does to an individual, the stress that's surrounding that. And throughout the US, there is a greater interest as to how social stressors increase all diseases, many different diseases, and lead to physiologic deterioration, especially among African Americans. And when you think about lupus, here's a disease where it disproportionately afflicts people of color. African Americans are afflicted 3 times more than Caucasians. So biologic factors can't fully explain or address the health disparities that we continue to see in lupus. And mind-body interactions may provide a more comprehensive understanding of why low-income communities and communities of color experience disproportionately higher rates of disease, healthcare utilization, and poorer outcomes. Now this is a very broad stroke. Clearly not every African American in the US is like this, but as a whole, African Americans compared to whites experience more psychosocial stressors associated with poverty and unemployment, as I mentioned, as well as exposure to violence and physical victimization. They experience environmental stressors related to racial, residential segregation and poverty concentration, and witnessing the crimes in these high poverty areas. So that leads to something. Something happens to people when you are in that type of environment constantly. And I don't know if you remember several years ago in the news, there's one particular town in Missouri called Ferguson where a white police officer shot a black man. And disregarding whether that was justified or not, what came out of that was this community outrage as to the circumstances around that, the justice around that, the reasoning behind that, and it really snowballed into something much greater. And you see here the demonstrations that occurred, the response to that in terms of the military having to be called in to calm people down. So it's not just the event of that police officer killing the individual. That was just the tip of the iceberg that we see as the initial event. But all of this represents what the community underneath has been wanting to express for so long, their dissatisfaction with how they're viewed, the injustice that they perceive that they may be having as a community. So I just put that as one example of what may be impacting people's minds, their souls, and eventually their health. So the first look at how this might impact people with lupus in our cohort, we looked at discrimination. And we took 578 African American women in one of the waves of gold, and we gave them this everyday discrimination scale that measures routine and chronic experiences of unfair treatment. And we also asked them if they said that they were discriminated against, whether it was due to their race or not. And the primary outcome was disease damage. And what you see here on the x-axis is discrimination, going from low to high, and then the damage levels. And it's a very interesting dichotomy, actually, depending on whether you attribute it to race or not. But there is a subgroup here that strongly felt that their race was not a factor in the discrimination, but it correlated in terms of the predicted damage. So all this to say really was, this is the first study to demonstrate that discrimination is associated with disease damage when you control for various factors in SLE. and that experiencing discrimination or perhaps other elements of psychosocial stress may be a source of the racial disparities that we see in SLE. So I'm going to change our focus here into providing some updated information on what we've been focusing on the past several years, and that's cardiovascular disease. So we know that in the general population, psychological stress contributes to atherosclerosis. There's various studies with that regard. In fact, there's even a study that showed 40% in that study with atherosclerosis had no other known risk factors other than psychological stress. Now, whether you believe that particular study or not, or the degree, there's many studies that clearly show that there's an element of stress and contribution to atherosclerosis in general. And when we think about lupus and cardiovascular disease, we know that it's a primary cause of morbidity and mortality, that there's a huge burden, that ischemic heart disease represents 16 to 17% in people with lupus, that 3 to 15% have strokes, and what's remarkable is that this is in a relatively young population where you wouldn't see this amount of burden. And many of you may be aware of John Esdale's key study that when he looked at a cohort of people with SLE and those with CVD, that when you control for age, sex, hypercholesterolemia, hypertension, diabetes, tobacco, traditional risk factors, there's still a very significant proportion of cardiovascular risk in lupus that's completely unexplained. And there are various other studies that fall short of explaining cardiovascular disease in terms of traditional risk factors and inflammation and disease activity. What is outside of this group that may be contributing to that? So along these lines, we have a sub-study of GOAL that we call PULSE. And that stands for People Understanding Lupus Through Shared Experiences. And the main goal was to look at cardiovascular disease among African Americans and whites with SLE in our GOAL cohort. And our hypothesis was that there would be a racial difference, there would be a greater burden of cardiovascular disease or CVD in African Americans, and that this was in part explained by the greater psychosocial stress experienced by African Americans in our group. So in the 2017 GOAL survey, we had 780 participants complete information, 80% of whom were African American. And we asked them various ways of trying to find potential cardiovascular events that they've had in the past up through 2016. And we did it through various ways. Self-report, obviously, we asked them very clearly, did you have a myocardial infarction, a stroke, and so forth. And then you remember that this build is a self-reported validated measure of disease damage, and within that component of build are questions asking about heart disease and strokes. And then this Georgia Hospital Discharge Database is a population database that I referenced earlier that we can match to. We know all the hospitalizations and emergency room visits of individuals in our GOAL cohort in the state of Georgia. And we looked for these admissions that had associated codes related to cardiovascular disease. And then we spent the time, given the heterogeneity and the extreme complexity of the American healthcare system, we had to individually go to every facility, request the medical records to be reviewed, and that took a very long time. But we eventually got 600 records, over 600 records that we reviewed for these events: myocardial infarction, angina, transient ischemic attack and stroke, and peripheral vascular disease. And what we did was we used published adjudication algorithms that I referenced in the bottom right. And at the end of the day, we had 23% of this group with adjudicated cardiovascular events. And as we suspected, African Americans had a much higher burden of cardiovascular disease compared to non-African Americans, 24.8 versus 14.7%, and that was statistically significant. Overall, regardless of what race or gender, there was a very high burden of people reporting some form of everyday discrimination. But again, as we sort of suspected, African Americans reported higher levels of not only discrimination, but non-specific general stress. And the type of stress, really the subcomponent in the measure, seems to be with components that have to do with loss of control. And that really drove a lot of their stress. And this is the data that we're very excited about, that's preliminary. We looked at, in a cross-sectional basis, the independent association between stress and cardiovascular disease, as well as the independent association between discrimination and CVD. And when you look at the univariate model as well as the multivariate model, where we controlled for age, gender, race, disease duration, disease severity, education, poverty, and various traditional risk factors for cardiovascular disease, including smoking, high cholesterol, diabetes, or hypertension, there remained an independent effect with statistically significant odds ratios. So where do we go from here? To our knowledge, that was the first description of stress and discrimination in lupus independently affecting CVD. But it's cross-sectional. It's an association that we want to then go to more a causal association, so you need a prospective design. So what we're gearing up to do is, we know those who've had previously a CVD event. We're looking at those that are CVD naive. We will follow them over time looking for incident events, and we'll try to obtain some causal information at that point. And I mentioned to you about all the biological specimens that we've obtained. I think what's important is to learn about the mechanisms, and certainly what is it about these environmental social effects that affect the mind, that then how does it affect the body? Through what mechanisms? Is it inflammation? Is it endothelial dysfunction? Is it cortisol dysfunction? Are there autoantibody differences? So I think it's a very important thing not only to bring up these causal inferences on a social level, in a mind level, but also to try to link it to biological mechanisms. But in the meantime, we also want to identify potential interventions that we can roll out into the population. What is it about how people are perceiving their status? Are there components of the way that people are managing themselves, their self-efficacy, that we can intervene on to improve some of these outcomes? There are maladaptive behaviors that we're following in terms of, are these people being driven to smoke more as a compensatory measure, and so forth. But not only do we want to focus on the negative aspects, there are so many positive aspects that we want to find out too. There are many people that, despite being a minority, despite having high disease activity and damage, they succeed. You know, that's the diamond in the rough that occurs in every population, is what is it about certain individuals that, despite all the headwinds of society, they maintain their status and improve. So we're looking to aspects of resilience, confidence, hoping to find ways to improve people's outcomes as well. I had the pleasure yesterday of walking around with Dr. Palacio, and it felt like we toured the entire country of Ecuador. But one of the many places that we went to was the Monument of the Middle of the World, and it's a great place. They had a small exhibit of the Ecuadorian sculptor and painter Guayasamín. And of those of you who know him, he went through a period of time that's called the Age of Wrath or Anger, where he witnessed a lot of social injustice. And he reacted in terms of the paintings of expressing that anger and wanting to do something about that. And so we as clinicians, when we see our patients, we definitely want to focus on the biology, the treatments, and so forth. But it's impossible to take away the social aspects. And so we must be advocates for our patients in terms of the political, the policy, and the social environments that influence so much the mind, that then influence the body of the people whom we serve. So even though these are not things that we're trained in medical school or other aspects, they are part and parcel, integrated with how we are going to improve the lives of those whom we serve. So I will end with acknowledgements. So many people to thank, but many of you know Christina Drenkard. And she came to help me at such a critical time when we got awarded the Georgia Lupus Registry. And Donato Alacan Segovia, I'll never forget the day when he called my boss saying, we have a wonderful person who's moving to Atlanta, who's an epidemiologist, who loves lupus, and I thank God for having this angel come down and to help me. But that's not really the case. Well, it's the case that yes, she did help me, but I've learned that I've been helping her. She's taught me so much along the way, and I think together we have learned so much to improve the lives of people with lupus. So thank you so much for your time.
Thank you very much, Professor Sam Lin. I think people can ask you in this moment. Is it good for you?
Oh, yeah, sure.
Por favor, si alguien quiere hacerle alguna pregunta al profesor.
Sam, thank you very much. I was impressed to see all the number of measures that you are trying to detect in this kind of very large population. And I wonder if you are able right now to identify some small number of measures that could be shared and applied in other populations around Latin America.
I think these are universal issues in many ways. I pause for a minute because I know that there are social and cultural differences. But as I referenced earlier, there are many universal factors. So there's undoubtedly aspects of what we're doing that can apply and translate to other populations. So I'm going to count on you and others and Christina to help us try to culturally validate and externally validate some of the measures that we have, because this is a universal issue, there's no doubt. And so yes, you make a good point that what we're learning in Atlanta is just a start of the universal issues that afflict all of us, all of our patients. So thank you for that charge.
¿Alguna otra pregunta?
Hello, Dr. Lim. First of all, congratulations for all the work you've done. I do have a question regarding the data that you mentioned and the interventions that will follow afterwards. You mentioned about the psychological interventions that might come up after you obtain all these data. However, there's a big correlation with the poverty that you showed in the population that you explored. So, have you done any further study to gain some depth into how the poverty is a factor for the psychological stress, and what are the factors considering regarding that? And also, have you thought about teaming up, or have you done it like with welfare programs in Atlanta to try to see what outcomes might come afterwards?
Thank you. Yes, that's the type of analyses that we're trying to do now. All of these covariates, these mediators and moderators that integrate with an entity like poverty, as you mentioned. What does that mean? How does that then translate to the various social factors that then lead to the biological outcomes that our patients see? We're starting that. This is data that we just finally cleaned and are presenting, so I admit that this is just the start of the work. I have people in that list. There's a whole group of social scientists that I depend so much on. I know as a physician that these factors are real. I was never trained like this, other than the training that I have day to day in the patient clinics that we serve. But these social scientists are amazing. The science, the rigor that they have, what's occurring in the literature is very important. And they are really helping me understand how to very scientifically address questions as you mentioned. Is there anything else that you mentioned?
No, I think
okay.
Thank you.
Gracias.
Very nice study, Doctor. In relation to the mechanisms, goes from the social difficulties and the biological activities, there are several studies about the epigenetic influence of the social conditions on the activation of inflammatory genes that is very good demonstrated. The problem is how can we develop this study in a clinical grounds to prove these activations. That's the problem. But the mechanism is very known.
Yes. I agree. And by the way, I did forget to mention, we are looking along the lines of epigenetic changes. We're also looking at telomere lengths as well. But epigenetics, I think, is a key. And translating that into the social component is what we hope and dream that we can at least try to help to do. Points well taken. Thank you.
Si no hay más preguntas, I want to ask you a question. I see many aspects when you counsel related to the mind diseases, but I can see the relation between poor food and nutrition with the mind diseases in these patients. It is because the poor food nutrition is related with mind diseases in all of the aspects. Then D vitamin disease deficiency is related with depression and anxiety, for example.
Yeah, absolutely. We have a lot of data regarding access to food and quality of food in the neighborhoods of our population as well. So we agree. I think that drives a lot of what we're seeing as well. And again, it's a very universal concept. It's different in how it's applied in certain countries and because of the socioeconomic status, but I think that's a very important issue. We have some PhD nutritionists that are beginning to look at some of that data in our group. And by the way, if anybody is willing to help with some of this data, we have more than enough to share. So please be in contact with Christina or myself. We'd be happy to collaborate with any of you. We need your intelligence.
Okay, thank you very much.